Hello, my name's Dr. Andrew Way. I'm from the Alfred Hospital in Melbourne, Australia, and I'm currently at the Munich 17th Acute Leukemias Symposium. At this meeting, there's currently discussion about the role of pro-survival inhibitors such as venetoclax and their newly found role in acute myeloid leukemia. Venetoclax and also glasdegib were both approved by the FDA on November the 21st, 2018. And this is the first time in many years where new drugs have become available for this very needy patient population. It's expected that over the next 30 years that the number of people over the age of 60 globally will top 2 billion people. And it's known that the majority of patients with acute myeloid leukemia don't do particularly well if they're elderly. And so new therapies in this area are extremely exciting and very much something we've been looking forward to for many years. The results suggest that from phase 1 trials that venetoclax, inhibitor of BCL2, when combined with either hypomethylating agents or low-dose Ara-C, produce very high response rates, 54% with low-dose Ara-C and 71% in combination with hypomethylating agents. Furthermore, median survival also appears to be substantially improved over historical results. For instance, with low-dose Ara-C, historical survival rates are expected to be around 5 months, whereas it appears to be doubled in combination with venetoclax. With hypomethylating agents, historical survival rates have been on the order of about 10 months, and this appears to be, again, almost doubled in combination with venetoclax. Randomised trials are currently underway, and we hope that these will potentially validate venetoclax as a new standard of care for older people with acute myeloid leukemia. The next frontier, therefore, is how can we further improve outcomes in combination with venetoclax? And some of this information has come from analysis of drug resistance mechanisms, and it's emerging that activation of kinases such as FLT3 and RAS, and potentially downregulation of p53 function appear to be important consequences in patients who have relapsed. So there are new trials being developed to look at triple combinations of venetoclax with low-dose chemotherapy in combination with either a FLT3 inhibitor to try and reduce the risk of FLT3 mutations from emerging, and also triplets in combination with other drugs such as histone deacetylase inhibitors to try and overcome the problem of p53 mutation. Again, we hope that the future will give us promising information on whether these clinical endeavours will be successful or not.